friends, we move on to the next module, which is the module on evidence-based surgery. You mentioned earlier that if you are going to be a good clinician and a good surgeon, your practice must be based on evidence to say that what you're doing is scientifically valid. Let's learn about how we go about looking at literature to see if it's really valid literature. The idea of evidence-based medicine, evidence-based surgery came up in the mid-90s when Sackett, who was initially in McMaster University, Canada, who later went on to set up the department at Oxford in the UK, defined it as shown in the slide. Basically, it means you are looking at judicious use of available best evidence, and just that is not enough. You have to integrate it with individual clinical expertise, individual clinical capabilities, and then decide that that is the best treatment for your patient when you face a clinical problem. But how do we normally do it? If you look at our own practice, many times you will notice it most prominently in workshops when discussions are taking place. Hardly any data is given to you. You know, the expert says, yeah, this is the way I do it and it works very well in my hands. We've had no problems. And when they say that, I'll bet you my bottom dollar, they have really not evaluated. There has been no follow-up of patients, say a year or 2 years later. And, you know, they contend that they've always done that. You know, this kind of approach does not find a place in evidence-based practice. And there's a paradigm shift. You know, we really have to go away from this thought process and come back to, you know, demanding data and evidence for what we do. Please note the date of this quotation. Ruskin in 1853 said this. So if you really want to be a scientist, you must substitute facts for appearances and demonstrations for impressions. The impressions that we have about all aspects of life that we look at are really extremely variable. And unless you have data to prove your impressions right or wrong, very little is achieved. I've said this before, and it's a repeat slide, but I put it up again to impress upon you that self-questioning, understanding controversies, evaluating facts before you take decisions is a very important part of our life as surgeons. So, coming down to the scientific value of studies, there are two fundamental questions that we ask. How recent is it? Something which was valid 30 years ago may not be valid today. So, basically looking at the previous 5 years to see if it is recent or not. And a little more complex question is the second one, which says, how much is it scientifically valid? And so, when you're looking at the age of the study, for example, how recent it is, then you will see that the source that you look for this information is very important. The information that you get in a textbook is at least 5 years old. Reviews in compendia are books like Surgical Clinics of North America, Recent Advances in Surgery, things like that are at least 2 years old. Reviews in journals, a few months old, and of course your conference papers are perhaps the most recent, because scientists or scientific surgeons who do a study and get a result, you know, bring it out to the open first in a conference presentation. They write it up, and a few months later that information appears in a journal if the article is accepted. So please note our constant habit of not going beyond a textbook, which is what I see in my postgraduates, actually means that you're looking at information which is about 5 years old. Now, what are the types of studies that exist and what are the ones with the best value? Studies may be either descriptive or evaluative. Both have equal importance. Now, if you have case reports, just a few cases, 3, 4, 5, 10 cases, you cannot extrapolate the information from that to the whole population. So it has limited value. If you have larger series, uh, like cohort studies, for example, where you study hundreds of patients, either prospectively or retrospectively, that has a higher value. Prospective studies where you have a protocol, you have a fixed method of collecting data and looking at a group of patients, which is a cohort, perhaps for the next 4 or 5 years, they are more valuable than retrospective studies, which means you're looking at already collected data. You had no control on the way you collected the data. So retrospective studies are of limited value. But the best way is to have randomized controlled trials. We will know more about it as we go along. But in these controlled trials, you have a prospective study of a good number of patients. You know exactly what you're looking for, that has been, the protocol or the methodology has been set, and you're accounting for what are called confounding factors, where factors other than the ones you're studying may be effective and you are accounted for it. And finally, you account for an observer bias. The evaluation is done by somebody else who doesn't know what the intervention has been. So that's called blinding. So when you do that, you get the best, unbiased, and clearly, scientifically, most valid results. The literature out there, remember, we are talking about how to look for and where to get evidence. And that's why we talked about the types of studies. And now we're looking at the literature that's available. It may be either primary or secondary. The primary literature are the ones that are what are called original articles. Here, if you're looking at treatment efficiency, you would have a randomized controlled trial to prove a drug A, for example, is better than drug B. If you're looking at diagnostic accuracy, even there you have set criteria and you have a controlled trial, but it need not be randomized. It can be just a prospective observational study. If you're looking at prognosis of a condition, you have cohort studies where you study a group of similar patients over a period of time. And likewise, if you're looking at quality improvement or prevention measures, you again do a randomized controlled trial. So these are what are called primary literature or primary reports of trials, and they have the limitation in that you may not have large numbers of patients. And if you want to increase the number of patients so that you can generalize those data to the overall population, looking at secondary literature. Secondary literature gets its information from primary literature, collates data of similar articles and then reanalyzes it, that's in a meta-analysis, or just summarizes it as it you see in a systematic review. And then you give it to the practitioners, to the clinicians, the information to the clinicians, so that they are backed by scientifically valid data in a large number of patients. And so you have similar secondary literature in the form of practice guidelines or critically appraised topics and consensus development reports and the like. But for us, the two most important secondary literature components are systematic reviews and meta-analysis. As I mentioned before, you have several types of studies, and if you want to look at the value of these studies in terms of its veracity, in terms of how you can apply it to your own patients, the best information you get are in systematic reviews and meta-analysis. Not only do they collect data from randomized controlled trials, but they also have a large number of patients because they have put several of these RCTs together. and so they are the best value. Cochrane collection or the collection from McMaster University has a very structured way of evaluating uh, various studies, including RCTs, and so they give you the best information you can ever get. RCTs were the double-blind studies where both the patient and the investigator is blinded about what the intervention has been is a very good study, but in surgery, it is very difficult to do a double blind. Even single blind studies are sometimes difficult, but they can be somehow managed. A single blind study is where the evaluating investigator is blinded about what the intervention has been, but the patient himself, the subject himself, knows what the intervention is. And so, if you look at this list, the anecdotal experiences, or what we might popularly call expert opinions, which is what we all go by. You get enamored, oh, Dr. Lakshman is the senior surgeon, he says so, and that's why I did it, is something which is completely unacceptable. When people speak, they must speak with the backing of data. And if you have no data on a given topic, then that is a good research opening for you. You can collect data, you can do a study, collect data, and that's when you progress in terms of surgical scientific approach. Now, some amount of statistics is required, and this is a really difficult area. I find statistics quite daunting, to be honest, but we have amongst us today an expert who's really good at statistics. He's even written a book on it, and he will be handling the module on basic statistics. But suffice it to say that if you have to evaluate a scientific work, there must be some basic knowledge of statistics. Peer review is another very important thing. There are people who have punched holes in the concept of peer review, where people feel that it may not be as good as it is, but it is the best available method we have, where people who are knowledgeable, who are experts in the same field as you are, if you write a paper, for example, on laparoscopic appendix, it will be shown to 5 other people who are experts in the field, and they will evaluate your work and see whether it is reasonable or not. And only when such evaluation is done and it passes the muster, they say that it is reasonable, only then such a paper will be published. And I think it is very important when we look for literature, particularly in this age of internet, that you make sure that whatever you read on the internet is peer reviewed. If it is not peer reviewed, it just isn't something that you can blindly believe. So when you look at the aspects that I've outlined so far about a journal, how recent is it? Was it an RCT? Is it a meta-analysis? Were the endpoints okay? Things like this. Then you are looking at the level of evidence for a statement that you make. Now, let's take an example. Is a drain after a laparoscopic cholecystectomy required? I'll say that it's not required. Right? It's not an expert opinion, because I know that there are RCTs which have been done which say that putting a drain is no better than not putting a drain as far as the outcome is concerned. So the level of evidence is the highest, number one. For that you need an RCT. But if you are basing your judgment on cohort studies, it will be level 2. If you're basing it on case control studies, it will be level 3. And likewise, if you're basing it only on an expert opinion with no data, it is level 5. Please understand that every question that you have, every thought that you have, cannot have RCTs. And so, practically we have to do something, but at the same time, we must know what is the level of evidence under which we are doing a particular thing. And if you find that the level of evidence is 3, 4, or 5, our attempt must be to do an RCT and see if we can get a level 1 evidence for a given clinical problem. So to get the evidence for whatever that you're doing, you must ask the right clinical question. You must look at what literature is available on the given subject. Once you get the literature, you must check the veracity, the scientific validity of that literature, which is critical appraisal. Then you apply that to your conditions, then evaluate it yourself. Once you apply and do something, it's a good idea to either do an audit or a project, research project, where you evaluate your own work and see if what you're doing is good for your patients or not. These are the 5 steps of getting evidence. It's not that for everything that you do in life you do this, but for at least the important things that you do, the common things that you do, you must have this kind of an approach, even in our day-to-day clinical practice. So, what is a good research or a clinical question to get at the basis of evidence-based practice? There are 2 mnemonics. One is PICO. Some people add the T and call it PICOT. And the second one is a finer. We'll look at these simple things and understand the basics. P stands for a population. So what specific patient population are you looking at? What is the intervention, I, that was done? Was it a good intervention? C stands for comparison. What are the main alternatives that were there for that particular intervention? And how good is one compared to the other? O looks at the outcome of interest. What do you intend to accomplish, improve, or affect? A classic example of this is that this is where most people slip in terms of designing a study or doing a study. For example, a chemotherapeutic regime may say that at the end of 6 months, okay, in say a metastatic carcinoma of the liver, the size of the tumor shrinks by 50%. Okay, it looks very impressive. You don't give chemotherapy, the size is say 10 centimeter diameter. You give chemotherapy, it is 5 centimeter diameter. But is that what we're looking at? What we really need to know in the outcome is, did the patient live longer with the chemotherapy? Overall survival, was it higher? Was his quality of life better because he got chemotherapy? Or was it no different? You'll find that most studies which do not measure quality of life or overall survival are not worthwhile studies. But if you look at the literature, most of it will be looking at something else other than these 2 important things. So, outcome of interest is something that we must always look at. And the time, the T in the PICOT stands for time, was an appropriate follow-up time to assess the outcome. Very important question. For example, 80% of hernias occur within the first 2 years. Okay, the other 20% occur much later. So a minimum follow-up for a hernia paper must be 5 years. As an absolute minimum, you may say at least 2 years. But if you have a paper on recurrence of hernia, which is evaluated for only the patients for only 1 year, it's useless. So this is the kind of questions you ask yourself. Look at FINA. FINA stands for feasible, interesting, novel, ethical, and relevant. It's same as PICOT, but looked at it in a different way. Now, if it is feasible or the adequate number of people, you learn the concept of sample size as you go along. But yes, the number of people that you have in the study is important. Was there adequate technical expertise? Do you have it in you to say, do a laparoscopic hernia repair? Do you have the surgeon in your team? Is it affordable? Manageable in scope? There are so many other administrative issues of a study. Can you manage? Can you manage that in there? And it has to be interesting. It has to be novel. Something that is new. Something different from what already exists. It must be ethically correct, and the most important of all, it must be relevant both to the scientific knowledge and the clinical and health policy. And of course, it must also lead you on to the next level of research as well as we go along. So the two main kinds of questions that you ask when you're looking for evidence-based information is PCOT and final. Validity of results, I'm repeating myself here, to some extent depends on how the results are evaluated. And when you do, you will learn more about it when we do the critical appraisal of papers and when you do the journal club later on in the day. You have to ask several questions about the validity of results themselves. It's about randomization, about any dropouts, if any, and the so-called intention to treat basis, where every single person who is put into one group is neither shifted nor taken away from your analysis. So he must remain in that group, whatever happens during the course of the study, and he must be, that number, that person must be included in your analysis. And that is the very basic requirement in your statistical calculations, whether there was blinding or not, were the two groups similar. If you evaluate an operation in two separate groups, one of them is younger and healthier, and the other one is older and has a lot of comorbidity. If that happens during your selection process, even if it is randomized, then you find that the outcomes will be compromised because they are not similar groups. And so this is the kind of question that you ask. Treatment other than the intervention, was it equal? These are what are called confounding factors. So if you're evaluating, say, a particular antibiotic on a diabetic foot infection, for example, you can't have other confounding factors like vascularity masking the issue. So everything else other than your intervention must remain the same in the two groups. And at a different level, when all this is done and you find that the study is useful, you have to ask very simple question as to whether the treatment effect was relevant. I mentioned the example of a tumor size, and was it a good measurement? For example, if you're looking at the size of a retroperitoneal tumor, if you undertake only ultrasound to evaluate the size of the tumor, it will not be good. We all know that ultrasound is not very accurate in looking at the retroperitoneal area. And so, as a minimum, you must have repeat CT scans if you are evaluating the response to treatment of a retroperitoneal tumor. And that is what you have to look at. And very importantly, can I apply this to my patients? So there are ethnic differences, there are differences in terms of physiology in different populations, and so if something which is done elsewhere geographically, can that be applied to us is a very valid question we have to ask. We talked about the relevance of the outcome, and very importantly, do you have the infrastructure to do the same things that were done in the study population, in the study center? If you do not have those kinds of skills or the infrastructure, then obviously you cannot apply those results to your patients. And that's a question you have to ask yourself before you institute a change in your practice based on a so-called evidence that well, that in short is what evidence-based surgery is, and the kind of questions that you ask before you say that a given evidence is valid. But please understand that, like everything else in surgery or medicine, there are different views on EBM. If medicine is to be a science or a learned profession, we need to think critically about how and why we make those decisions. This is again supporting evidence-based medicine. And again, remember that it is not only going by what you read in papers, however good those papers are. You have to have both individual clinical expertise and the best available external evidence. And neither alone, I keep repeating it several times, neither alone is enough. Thank you, and that brings us to the end of module 2. Perhaps we can have a discussion on this for the next few minutes before we move on to the next module.